Good morning, and welcome once again to the second edition of the Advanced Fetal Echocardiography Workshop course. For those who may not know me yet, my name is Ignacio Smith Montaño Callejas. I am an obstetrician gynecologist, and I also serve as an assistant professor at the Faculty of Medical Sciences at the University of Santiago de Chile. I am part of the Obstetric Ultrasound and Fetal Echocardiography Unit at Clínica Indisa, Integra Médica, Roberto del Río Hospital, and San Jose Clinical Hospital. I am the Secretary General of SOCHUMB. I am now going to present two left ductus-dependent heart conditions, aortic coarctation and interruption of the aortic arch. Aortic coarctation is a narrowing of the aortic arch, and about 90% of cases occur specifically at the aortic isthmus. It accounts for approximately 6% to 8% of all congenital heart diseases, and about 4% to 7% of congenital heart diseases diagnosed prenatally. It occurs at the isthmus between the left subclavian artery and the entry of the ductus arteriosus. This area is the aortic isthmus, and that is where the aortic coarctation will occur. Here we have a very representative image in which we can clearly see the pulmonary artery, the ductal arch, and the ductus arteriosus draining into the descending aorta, and we can also clearly see the ascending aorta, as well as the transverse aortic arch with its supraaortic branches. Here we have the brachiocephalic trunk, the left carotid artery, and the left subclavian artery. So the coarctation is going to occur right in this particular area, located between the left subclavian artery and the opening of the ductus arteriosus. Here we have an image in which you can clearly see exactly where the aortic coarctation actually occurs, again in the area located between the left subclavian artery and the ductus arteriosus, that is, right at the level of the aortic isthmus. Aortic coarctation is a narrowing of the aorta that will cause an obstruction of blood flow at the level of the aortic isthmus, and it can be divided into preductal, which accounts for 2% and is the type of coarctation that can be suspected on diagnosis because there is tubular hypoplasia. In addition to the transverse aortic arch and the post-ductal type, which accounts for 98%, this is common in older children and adults, and prenatal diagnosis in this case is difficult because the aortic arch is normal in this case, and it will become apparent when the ductus arteriosus closes. Aortic coarctation is generally only a diagnosis that is suspected during fetal life. Definitive confirmation or exclusion is usually made after birth, once the ductus arteriosus has closed. There are several indirect ultrasound signs that can raise suspicion, such as an early predominance of the right heart chambers compared with the left-sided cavities when the ventricular ratio is greater than 1.4. A clear and evident discrepancy in size between the aorta and the ductus arteriosus on the three-vessel trachea view at the V convergence, where the ductus arteriosus will clearly predominate relative to the aortic isthmus. A reduced caliber of the transverse aortic arch, and there may also be flow acceleration and anatomic narrowing of the isthmus. In more severe cases, there may be reversed blood flow within the aortic arch, as well as reversed or inverted flow across the foramen oval, meaning flow from left to right. The indirect or suspicious ultrasound signs, here we see that the right-sided chambers are dominant compared to the left-sided ones, with a very small left chamber. The earlier the gestational age at the time of diagnosis, the greater the likelihood that this represents an aortic coarctation. False positive findings can occur in the third trimester, and the more severe and more extensive the degree of symmetry is, the greater the likelihood of aortic coarctation. There is no single definitive cutoff point, and once an aortic coarctation is suspected, the pregnant patient should be promptly referred in a timely manner so that a fetal echocardiogram can be performed as soon as possible. images in which we can observe right-sided dominance compared to the left. Here, we can see the ascending aorta with a somewhat smaller diameter. Here we can see a 3-vessel view in which we will be able to identify a 4th vessel to the left of the pulmonary artery, which would represent a persistent left superior vena cava, which has been associated with obstructive heart diseases, as in this case, an aortic coarctation. And here we can see that there is a dominant diameter of the pulmonary artery compared to the aorta. In the sagittal view, we see a narrow aortic isthmus in the 3-vessel trachea view. Color Doppler is present with antegrade flow, and there is a narrow aortic arch. In the apical 4-chamber view in grayscale, there is right-sided chamber dominance compared with the left. On color Doppler, it is also seen that filling is greater on the right than on the left. Prenatally, aortic coarctation has a high false negative rate, with a rate greater than 50-60%. It also has a high false positive rate prenatally, fluctuating between 60 to 70% of cases. Even after birth, coarctation still has a relatively high false negative rate at approximately 50%. Therefore, diagnosing aortic coarctation will help reduce both mortality and morbidity in these children. The direct signs must be evaluated, and a detailed examination and measurement of the aortic arch must be performed. All structures must be measured in their dimensions at the level of the aortic valve annulus, at the level of the ascending aorta, at the level of the transverse aorta, at the level of the isthmus, at the level of the descending aorta, and also at the level of the ductus arteriosus, in order to compare the relationship between the isthmus and the ductus arteriosus. Normal 078. Aortic coarctation is a very difficult prenatal diagnosis. We have already seen that there is a discrepancy in ventricular size, with right side dominance compared to the left greater than 1.4. There is also another parameter to consider: the diameter of the left carotid artery compared with the diameter of the transverse aortic arch. Normally, it should be greater than 0.78. When this diameter is decreased, it indicates that there is a suspicion of aortic coarctation. Schneider and colleagues have published the Z-scores, and these Z-scores can be downloaded. There are applications that you can download to devices, to a cell phone, or to a computer, for use when you are performing an echocardiogram and want to calculate them when there is a suspicion of aortic coarctation. And all structures must be measured at the level of the aortic valve, the pulmonary valve, the ascending aorta, as I mentioned, the transverse aortic arch, and the descending aorta. One of the best predictors for aortic coarctation, and the most sensitive, is at the level of the aortic isthmus, and it must be measured in the 3VT view, in the 3-vessel trachea view, right at the level of the convergence of the V at the level of the aortic isthmus. And for example, in this case, when we have a 23-week pregnancy with an aortic isthmus of 2.5 millimeters, it will have a normal Z-score of minus 0.61. The same patient with an aortic isthmus measuring 1.5 millimeters in diameter would have a markedly abnormal Z-score of 3.72, which would raise suspicion of aortic coarctation. Let's look at some examples. This is a patient in whom, on the 21-24 screening, it was assessed that there is right-sided dominance. In addition, she had an apical muscular VSD. Here we can see the right-sided dominance. It was not so evident because she had the muscular VSD. In addition, she also had a perimembranous VSD. The diameter of the great arteries was decreased. There was pulmonary dominance compared to the aorta, and on the 3-vessel trachea view, in relation to the aortic isthmus, there was dominance of the ductus arteriosus compared to the aortic isthmus. Here we see color Doppler with filling predominance at the level of the right chamber. Here it can be clearly seen that the aortic isthmus measured 2.9 millimeters and the ductus arteriosus 4.2 millimeters. Here we again see right cavity dominance and great artery dominance on color Doppler in the 3-vessel trachea view. with antegrade flow in both and a reduced caliber at the level of the transverse aortic arch and the aortic isthmus. Additionally, this patient had an aortic isthmus to ductus arteriosus ratio of less than 0.7, whereas in a normal case, this aortic isthmus to ductus arteriosus ratio must be greater than 0.78. So when this patient was born, it was confirmed that she had an aortic coarctation and she underwent surgery at a private facility in Santiago. Another case with a high probability of aortic coarctation. Please note here the dominance of the right-sided chambers compared with the left-sided ones, the three-vessel view, and there is even an aortic arch here with reversed flow, which is not typical of coarctations, but in that case it was present, and the aortic coarctation turned out to be a false positive. When it is suspected before 24 weeks, before that 24-week mark, the positive predictive value is 80% that it truly is an aortic coarctation, and those patients in whom it is suspected before 24 weeks may be more strongly associated with chromosomal abnormalities. When the suspected diagnosis is made after 28 weeks in the course of the third trimester, the positive predictive value will decrease to 30%, which means it is most likely to be a false positive. A patient was suspected of having aortic coarctation and it was a false positive. Please note a wide arch and a transverse aortic arch with a smaller diameter. It was a false positive. The suspected diagnosis was made in the third trimester. Another false positive, four-chamber view, Doppler predominance, color filling within the right heart chambers, a smaller diameter ascending aorta, and it even had a more vertically appearing course. In the three-vessel and trachea view, there was a wide ductal arch with reverse flow in the aortic arch. Here it can be seen in grayscale, and the transverse aortic arch was practically not visible. The colleagues who referred this patient even suspected for a moment that it might be an interruption of the aortic arch. Please look here. Three-vessel view, a wide ductal arch, and it cannot be seen. Here, you need to make a slight transducer movement to be able to see the transverse aortic arch, and for a few moments it had reversed flow. A patient is born, a newborn echocardiogram is performed, and the cardiologist reports a hypoplastic ascending aorta and aortic arch. At the 3-month follow-up, there is an aortic arch without coarctation and a persistent left superior vena cava that drains into the right atrium through the coronary sinus. This patient then did not have coarctation. Another case, here we have clear dominance on the four-chamber view and on the three-vessel view. Please note how there is right-sided dominance, and on the three-vessel view, the ductal arch is wide. The aortic arch has a smaller diameter but shows antegrade flow on pulsed Doppler. In the three-vessel view, there is antegrade flow in both. The aortic arch has a smaller diameter, almost half compared with the ductus arteriosus. Here, in the three-vessel view, we see the pulmonary trunk is very dilated, and please note that the size of the aorta is very similar to the vena cava, which is essentially suspicious for aortic coarctation, and that patient did have aortic coarctation. Another case, this is a patient who, on the four-chamber view, had a large mid-third muscular VSD. You can see it here even without color Doppler. With this patient, you need to be very careful because she does not show a symmetry of the cardiac chambers or right-sided dominance, or she shows right-sided dominance, but only very mildly. Please note there is bidirectional flow on color Doppler. In the three-vessel and trachea view, we see the same here, an aortic arch with a smaller diameter. This patient also had reverse flow in the aortic arch. Here you can clearly see the smaller diameter aortic arch and the reverse flow in the aortic arch there, and there was a high suspicion of aortic coarctation. Here you can see a narrow aortic isthmus on the sagittal view. Please note here that after the left subclavian artery, the isthmus is very narrow. This patient is born, and it is confirmed that they have aortic coarctation with a muscular VSD. This patient had a decompensation 12 hours before surgery and presented with hypovolemic shock, even with a prostaglandin infusion. A hybrid procedure was performed as immediate treatment, a ductal stent and banding of the branches to the pulmonary artery, so that later, once stabilized and with weight gain, the surgery for the aortic coarctation could be performed. The progression or association of this heart disease may be linked with other heart conditions, with other congenital heart diseases, and with chromosomal abnormalities, such as the most common one, Turner syndrome, and trisomies 13, 18, and 21. Also, in critical aortic coarctation, it may progress to left ventricular hypoplasia syndrome. For that reason, once aortic coarctation is suspected in these patients, and if it is a critical aortic coarctation, follow-up is necessary, and the echocardiogram should be repeated in 3 weeks to assess the growth of the cardiac structures, because it may progress to left ventricular hypoplasia. Treatment with prostaglandin infusion, interventional catheterization, and surgery. The surgery is performed with cardiopulmonary bypass and circulatory arrest under deep hypothermia. It may involve an end-to-end aortoplasty. A thoracotomy is performed. The aortic coarctation is resected at the narrowed segment. The ductus arteriosus is closed, and an end-to-end or extended anastomosis is done if the aortic arch is very hypoplastic using a left subclavian artery flap. And now we are going to talk about interruption of the aortic arch. It is a critical, ductus-dependent congenital heart disease that is uncommon in newborns and accounts for 1% of all congenital heart diseases. There is a loss of anatomical continuity of the aortic arch between the ascending aorta and the descending thoracic aorta. There is a classification. It is divided into type A, interruption of the aortic arch, type AB, interruption of the aortic arch, and type C, interruption of the aortic arch. The most common finding is type B, interruption of the aortic arch, 50-60%. The interruption is between the left carotid and the left subclavian arteries. Type A, 30%, occurs at the level of the aortic isthmus after the left subclavian artery. And type C interruption of the aortic arch is the least common type, 10%. It is between the brachiocephalic trunk and the left carotid artery. The diagnostic criteria include the presence of a subaortic VSD, subvalvular aortic stenosis, an ascending aorta with a smaller diameter and a more vertical course, and on the 3-vessel and trachea view, there will be an interrupted aortic arch, subaortic VSD, ascending aorta with a more vertical course, an altered diameter on the 3-vessel view, and an interrupted aortic arch on the 3-vessel view. Here we see the subaortic ventricular septal defect, the verticalized ascending aorta, the ascending aorta, the subaortic ventricular septal defect. The ductal arch again appears enlarged here when applying the double collar Doppler, a smaller diameter ascending aorta with a verticalized or ascending course, and it takes on this Y shape in type B interruption of the aortic arch. In 2015, we presented a series of clinical cases at the World Congress of Perinatology in Madrid, Spain. A series of 3 clinical cases that were diagnosed late. The first 2 cases and the third case in the second trimester. Here we have the images of the 3 cases, and the third one presented with a fetal demise at around 28 weeks. because this patient also had high drops, and the diagnostic suspicion was made based on cardiac screening following Jaegel's 5 views. Please look at the 4-chamber view. All 3 had normal 4 chambers. In the 5-chamber view, there was a malaligned VSD. In the 3-vessel and trachea view, there was a lack of continuity in the transverse aortic arch. All 3 have a subaortic VSD. The ascending aorta is straight with a more vertical course. The aortic arch is left-sided in all 3. Regarding associated congenital heart disease, all 3 had subaortic stenosis, and the second had an aberrant right subclavian artery. Extracardiac anomalies. The first had agenesis of the corpus callosum, and the second and third had none. The type of surgery in the first case was corrective surgery. In the second, it was a palliative Norwood procedure. It was managed as left ventricular hypoplasia because postpartum an echocardiogram and an MR angiography were performed, and there was also a hypoplastic ascending aorta. Therefore, a Norwood procedure was chosen. And the third case, as I mentioned, resulted in a fetal demise at 28 weeks. The first case had genetic testing that was normal. The second case had a 22q11 deletion, and the third case was Turner syndrome. We have an anatomical specimen of a type B interrupted aortic arch, and we can see that the interruption is between the left carotid artery and the left subclavian artery. Here we are evaluating a sagittal view of the ductal arch. A wide, straight ductal arch is seen. In the 3-vessel trachea view, the ductal arch is wide. Regarding the aortic arch, only the ascending aorta is seen, and the transverse aortic arch is distorted because it is interrupted. The VSD is seen here with bidirectional flow on color Doppler, a wide ductal arch, and an ascending aorta with a more vertical course and a smaller diameter. You can see the CIV here. That was one of the examples of interrupted aortic arch. Here, this is a case from last year, a recent case, that in addition to the interrupted aortic arch, also had another heart condition. It involved a double outlet right ventricle with left ventricular hypoplasia and an interruption of the aortic arch. Here, the ascending aorta can be seen overriding by more than 50% over the VSD, and the ascending aorta has a more vertical course. And the most characteristic finding, the one that guided us toward the diagnosis, was that the 3-vessel trachea view was abnormal. That is, the V view was already abnormal. Only the ductal arch and the ascending aorta are seen, and there is interruption of the aortic arch. Please note here in this image, the wide ductal arch, and here the ascending aorta and the continuity of the transverse aortic arch cannot be seen. This was an interruption of the aortic arch. Here we see the ascending aorta with a smaller diameter and a straight, more vertically oriented course. And additionally, this patient had a double outlet right ventricle, a hypoplastic left ventricle, interruption of the aortic arch. And when this patient was born, it was also confirmed postpartum that she additionally had pulmonary venous drainage and was classified as beyond surgical reach. Here we can see an image that shows a wide ductal arch along with a type B interruption of the aortic arch. Here are the images. Please remember that in fetal life, the most representative image of interruption of the aortic arch will be when the characteristic V on color Doppler is lost. We will see a wide ductal arch, and here we will only see the ascending aorta, and we will not be able to see the transverse aortic arch because it will be interrupted. This is a surgery for an interrupted aortic arch, where you can see here that a large pulmonary artery emerges from the right ventricle, with a diameter considerably greater than the ascending aorta, which appears smaller, almost half the size, and this is an interrupted arch, a surgery for a type B interrupted arch, where you can see the interruption here. You can see the brachiocephalic trunk, and the interruption is between the left carotid artery and the left subclavian artery. The 5-year childhood survival rate for these children is slightly above 85%, and the long-term survival rate is approximately 76%, with some children still alive at 15 years. Type B interrupted aortic arch is associated with chromosomal abnormalities in 50–80% of cases, and it is also associated with genetic syndromes such as 20q11 in 30–36% of cases. It is also associated with extracardiac anomalies, such as those of the central nervous system, such as I mentioned, agenesis of the corpus callosum, musculoskeletal, gastrointestinal, genitourinary, and also some rare syndromes. In conclusion, we may say that interruption of the aortic arch, being a critical congenital heart disease that is ductus-dependent, will have a high mortality rate without timely treatment. That will occur due to acute cardiovascular collapse or heart failure after the spontaneous closure of the ductus arteriosus within 48 to 72 hours when the ductus arteriosus closes. This heart condition requires, from birth, the administration of prostaglandin and subsequent surgical reconstruction of the aortic arch. In the neonatal period, interruption of the aortic arch is an uncommon heart defect, and there are clear echocardiographic criteria that allow its presence to be suspected. Prenatal diagnosis is important to prepare the perinatal and cardiology team, and thus provide optimal management for the newborn. Thank you very much, and we will see you at the workshops on Mondays and Thursdays starting at 7:30 p.m., where we can share your concerns and some questions and clinical cases that will be discussed live with your participation. Thank you very much.